everything that we do in oncology is to make sure that those of you with neuroendocrine cancer in this room live for as long as possible and as well as possible. It has to be about quantity and quality. And so I think everyone on this panel would agree we would absolutely never change therapy just based on a biomarker, except with very rare exceptions. So what are these biomarkers that I'm talking about? So this chromogranin A, the problem with it is that there are assays all over the world that are completely different. So our European colleagues claim that theirs is better than ours, but ours is not so great. We know that when you're on certain medications, it's going to be falsely elevated. But again, equally, if not more importantly, if I don't see your disease growing on imaging, I have to be very careful on when I'm treating you. Now, if you start to develop symptoms or pain, different story, right? But if you are asymptomatic, or at least your symptoms are stable, and all of a sudden a biomarker goes up, I don't know, it's not reliable enough. So that's my problem. I don't know, is that falsely elevated because you're a little dehydrated or some medication made it off, which is what happens at chromogranin, or if there's truly a sign. But I can tell you, if the disease is growing, it will declare itself. And then when I see it on scan growing, I know where to go to treat it. I get very nervous, and I have many patients that come with graphs of their, because we want to be empowered, just like Marianne shows, and a lot of people in this room I care a lot about, and they understand that because they've seen it, or, and when, yes, there could be a trend up, but eventually something should be seen on imaging that says the cancer is growing, because we want to be like the people in the room that live for 30 plus years. And so in my opinion, that is, we are playing our cards carefully. So I know I didn't actually answer the question. I'm going to get back to the question, but I just want to be very careful on biomarkers. The biomarkers that matter are like carcinoid syndrome and carcinoid heart. We want to know if you're making that carcinoid syndrome and that serotonin and all the other vasoactive amines that are associated with it, we want you to be protected with somatostatin analogs and treating that disease as much as we can, so that you don't get the carcinoid heart, which can be so debilitating and terrible. If you have pancreatic neuroendocrine tumors and your glucose is 10, I want to know how your insulin and proinsulin and other things are doing that are causing those symptoms. But chromogranin is a marker, but it's not a hormone marker. So chromogranin is a protein that's shed. So, colon cancer, our biomarker there is CEA, which is just a protein that the cancer makes, and it's the same thing with neuroendocrine cancer. So chromogranin by itself is not a hormone. And so serotonin is, and so to be honest, I don't even know what labs make or don't make those numbers, because I'm not a big believer in them to follow routinely. I think you always have to ask the patient, how are you feeling? To Marianne's question, it's not okay for you to say, yeah, diarrhea is fine. Well, you really got to tell us if it's not fine. If it changed, I need to know, because that may suggest that the cancer is making more hormone and we need to treat it. So I think we just have to be very careful and mindful of how we're using those tests. Not to say that, if you have a hormone secreting tumor, that is an important biomarker for us to use. But if you have a non-hormone secreting tumor, I'm just very reticent to ever make a change in my patient's management just because that marker went up without something showing me on imaging, whether it's PET or on scan, that it's changing.
Thank you.
Yeah, I agree with that.
One important thing too, there's a little bit of a generational factor to it, because 30 and 40 years ago when Dr. Zaks first started working, there was no PET scan. The Altria scan is terrible. CAT scans were barely just kind of working. But now we can see things, and not just in neuroendocrine, but like prostate cancer and other things, we can see things much more clearly. So everything that Dr. Reedy says is 100% correct, because very, very few people die of a biomarker. Right? You may die of an elevated bilirubin. You may die of an elevated, problems with your liver, your kidneys. But rarely does anyone die of an elevated chromogranin.
I'd like to echo. I think that, a lot of, we do see patients who come to us and they get focused, on blood work or lab result or x-ray finding. But remember, we treat the patient. I try not to focus on treating a specific value or a specific finding per se. I have to treat the entire patient and make sure that everyone gets the appropriate therapy. So I agree completely. I'm I really very rarely order biomarker for many reasons, except for the symptomatic or hormonally active patient. I almost never get biomarkers. And I have a story to share later.
Thank you. So, like any medical doctor, including oncologists, and even surgeons sometimes, we use a combination of signs, symptoms, labs, imaging to treat and make decisions on how to treat our patients. So exactly that. It's history, your symptoms, it's physical findings, can be sometimes laboratory tests, certainly imaging, and we use that and put it together and make a decision on how to proceed with each patient. And that's the important thing. I personally do follow chromogranin and serotonin. I've personally found the pancreastatin to be completely unreliable in the labs that I use. Chromogranin can be unreliable as well. It's affected by medications, including proton pump inhibitors. It can be affected by concomitant illnesses. But if you, and I never take, and I've done this in my entire career, I never take a single laboratory result, a point in time, as an indication to treat or not to treat. We're always looking for trends anyway. So serotonin, very important because of its effect on the heart and symptoms that it produces. Chromogranin may be important. It may indicate progression of disease, but in and of itself, I don't base any treatments of it. It has to be used in conjunction with symptoms, physical findings, and imaging. For Eric, is a fusion scan more accurate than a CT with contrast? And should a NET patient with a well-defined NET be automatically given the fusion scan?
Yes.
Totally agree.
I'll elaborate while he flips through the cards a little bit. So I think the fusion scan, I think that the person is asking about is whether you can take the PET portion of it and combine it with the anatomic portion of it. That should be done every single time routinely. Very, very rarely in the United States anymore do we have PET scanners that don't have the fused capability. So if they're not fused, it usually means that one, it came over on a disc unfused and someone has to fuse it, or it means that you go to a hospital that probably should upgrade their machine.
I guess I do want to just expand on that. I do think, though, that there's still some data that can be obtained from some good MRIs with contrast. Now, some places can give an MRI with contrast and do an MRI dotatate scan concurrently. We can, so that's how our approach. Many places can't give an MRI with contrast and a dotatate simultaneously. So sometimes for liver surgery planning, the contrast enhancement is needed for determining resectability or planning your surgical options. Would you agree, Eric?
No.
No? Okay.
So I don't agree at all. So I have a beef with PET MR. The pictures that come from a PET MR scan, I think, are inferior. And it's a very expensive machine. And when you take a PET and you fuse it with a CT scan, those images are about as good as it gets. And the reason I say that is because there's a lot of movement artifact in it when you have a PET scan. And so, trying to absolutely align it perfectly doesn't really mean anything. But what you can do is you can take the PET portion of it and the MRI, right? They can be two totally separate images, two totally separate studies, and you can still fuse them. And so you can still see them and stuff like that. And so the reason you get an MRI, right, specifically for, Aaron is correct, is to look at the liver. The MRI is more sensitive at finding liver lesions. However, the PET is the one that will discriminate between what is a neuroendocrine tumor and what is not a neuroendocrine tumor, so that when we do the liver surgery, we have a better understanding. Moreover, the anatomy is actually sharper with a CAT scan, a very, very clear, good CAT scan with contrast is much sharper so that I can figure out where the vessels are and how they are related to it, especially in like a very difficult place like the pancreas or the portal region. So I feel very strongly about the way that you image them and what you can and can't do with the images and how they go together. I do not like PET MRs.
Third opinion. I think importantly, it has to be apples to apples. So if you're following stage 4 disease, for example, good quality CAT scan to a good quality CAT scan, or MR to MR. If you have disease in places that aren't easily seen on CT or MRI, like in the bone, I do think a PET scan could be more helpful there. But there's, getting back to many of our patients are going to live for a very long time, and so routinely following for PET is not something we like to do, and insurance companies would hardly ever do it, in part because, again, we want to do scan to scan, and we're going to have a lot of them over our lifetime. So just being careful that you're consistent with what you're doing. But I do agree that good quality, what we call anatomic imaging, when you're looking, can be very helpful with a good quality CT or MR. And some PET scans, as we know, will light up normal tissue that's not NET. So parts of the pancreas may light up because there are somatostatin receptors there. It's not neuroendocrine, it's just part of the pancreas and parts of the thyroid gland as well.
Yeah, let me just say that not all PET CTs, not all PET CTs are the same. The companion CT in many centers are not the high quality diagnostic CT that's used. So there's sometimes a choice for the doctor to order PET CT with a diagnostic CT scan, which will be much higher quality. One more question on I'm sorry.
Sorry, just to follow up on that, how do you know which one you have?
Your doctor knows. Yeah. It might be on the report as well.
At the top of the report, it says procedure. And it'll tell you if it's a PET CT or a PET MR or just a PET or PET with contrast or without contrast. It should say it all up there. It always tells you the agent that's injected too. So it'll say like gallium-68 dotatate 4.8 blah blah blah, or copper-64 dotatate blah blah blah. The biggest problem that most people get, unfortunately, when you don't see a neuroendocrine specialist, is frequently you'll get a PET scan, but it will be an FDG PET scan. And that is not the usual test. Sometimes we do, but it's not the usual test we get for neuroendocrine.
Right, does everybody know what an FDG PET scan is? That's the glucose PET scan that we use for routine oncology studies? Okay. Can you explain the difference? I think that'd be helpful. Sure. The FDG scan, maybe Eric, you want to do that better?
I'll explain. So just so everyone knows, a PET scan is basically a biologic scan. So when you get like a CAT scan, it's just, they're x-rays, super, super fancy, very, very sharp x-rays. And so you can see the anatomic things, but you can't see anything biological about it. And so a PET scan, what you can do is you can either inject sugar, right, and find out where the sugar goes, and that will generally give you a sense of, because cancers generally, it's not 100%, but generally will eat a lot of sugar, right, because they're very aggressive. Neuroendocrine tumors in general are not quite as aggressive, so they don't eat as much sugar, okay? So that scan is not as helpful for certain types of neuroendocrine cancer. However, the dotatate PET CT, what it does, it marks the receptor that is classically on neuroendocrine. Again, it's not 100%, but classically it is. And so a lot of them will show up. So what we do is we take the PET portion of it and we overlay it on the anatomic portion of it. So it's a little bit like taking color and putting it on top of a black and white picture. So the black and white picture will be very, very sharp, for example, but then if you add some color to it, then it can actually give you more information. So you get biologic information in addition to anatomic. So that's really important because if there's a lymph node, let's say your lymph node is small, right? So like the pictures that Aaron showed, we can't tell because it's gray. It's just black and white and gray, so you can't tell. But then when you put a dotatate image to it, it goes boop, it lights up, and I can find it. Actually, what Dr. Reedy said about the bone is actually incredibly important, because now we can find new lesions in the bone to find out if your disease is progressing, if it's kind of changing, if it's growing. And the bone classically is very difficult to image with CT and MR because you have to lie in the machine for so long, and they're hard to find. Whereas with the dotatate scan, you can see it because the contrast is so fantastic. you can see it very clearly. So having all that information prior to diving into an operation or starting therapy is super, super important.
Thanks. One more question on scans, and then we'll move on. From the audience, someone asked, is it possible a gallium dotatate scan could be interpreted or administered incorrectly, and could a person be positive instead of negative? Well, of course. I mean, you've got to have the right person giving the scan, and more important, you've got to have the right doctor reading the scan. And I have to tell you that when my patients go for second opinions, especially to Sloan Kettering, they are very skeptical about scans coming from any place else. So everything is reread there, and if they don't like it, they're going to repeat it.
I will say one thing just to be very careful about. The SUV, so how bright the tumor lights up on imaging, can vary. That does not signify progression or if it changes. So again, back to that, we want to be very careful of when we decide to change therapy. So if an SUV goes from 4 to 6 or even 4 to 14, that doesn't necessarily mean progression. Sometimes, depending on when the somatostatin analog was given, it can be often changed. So just be mindful, disease progression is new disease or increase in growth, as opposed to a change in the SUV.
Okay. Thank you.
No one dies of an SUV.
So somebody asked if the slide that Aaron showed with the patient with the rash, if that rash was a type of flushing that's seen in carcinoid syndrome, and the answer is no. The carcinoid syndrome flushing is a deep reddish, almost purplish color from the neck above, mostly the neck above, can be on the chest as well. It is dry, and it is an intense heat. If there's moisture in the rash, it's not a typical carcinoid syndrome type rash. But the picture he showed was not a typical carcinoid syndrome rash.
So that was a patient who had a functioning tumor of the pancreas known as a glucagonoma, and it's uncommon, but it gives a particular rash with a bullseye pattern and some glucose abnormalities as well. So, but that was, that could be found, typically found in the perineum, so around the leg area or the armpit. But she had it on her chest. She also had a beefy red tongue and all the other features that go along with that kind of hormonal function, rare tumor. But I can assure you, I have colleagues who are busy with similar practices, but these tumors are very uncommon. Glucogenomas.
A couple of questions for Dr. Zaks. Can an SSA receptor negative patient still get carcinoid heart disease? Number one. Number two, how often should scans be done on a heart when you have carcinoid syndrome? And number three, does carcinoid syndrome cause atherosclerotic plaque in the heart or the thoracic aorta?
I'll take the last one first. The plaque related to LDL cholesterol is completely different from the plaque caused by serotonin receptors. So that's completely different. It's the reason why you have to make sure that you look at cardiovascular risk factors in addition to the carcinoid-related issues. I have to ask Diane if if she's ever seen a patient with carcinoid heart disease without receptors, because I can't answer that question. I don't remember seeing a receptor-negative patient with high serotonin, but I'd ask Diane about that.
Yeah, I think that would be unlikely, but I think importantly, it's not so much the receptors. If you have anyone with the syndrome can get carcinoid heart. So, I think sometimes we may have mixed response of somatostatin receptors where not all the tumors are bright on PET imaging. But I would say the vast majority that I'm aware of would have receptor positive. And certainly anyone with the syndrome stays on somatostatin analogs.
And there was one other question
How,
in there.
how often do you want to do scans on heart scans on patients that have carcinoid syndrome?
Okay, so we'll start by just saying that if you don't have carcinoid syndrome, I still think that a neuroendocrine tumor patient deserves to have an annual echo, not so much because you think they're going to develop the carcinoid syndrome, but to look for all other issues that you can check on when you do an echocardiogram. For a patient with carcinoid syndrome, it varies. We may do an echo every 6 months, or if patient has aggressive disease with uncontrolled serotonin, we may do one every 3 months. It would be unusual for us to do one more frequently than every 3 months.
Thank you.
Yeah, I would agree. I think, since so many patients who have metastatic disease of carcinoid tumor are on a somatostatin analog agonist, so we often would get echocardiogram every year in patients whether they have symptoms or not.
Thank you. There's a couple of questions here about liver metastases, so I'll try to put them together. What can we do? What can patients do? What can doctors do for liver metastases? And again, that all depends. So certainly isolated, low number of liver metastases that are in good locations and amenable to surgery, surgery is always a possibility. If it's a bad location, can't be reached easily, we can do radiofrequency ablation or even embolization if it can be reached. Those are possibilities. Then, aside from that, we then deal with systemic therapies, I think, right?
Correct. I think, and to be honest, it's not one or the other. Sometimes it's multiple. So we've had patients who we would do, surgery, ablation of some sort, and then ultimately even embolization. So they're not done in vacuums, and they're all part of the options we have for patients, and they're all, and some patients may have utilized all three modalities, or and there are other even options that we use less often. But so I think it's important not to think of them as individual, but as options available to patients.
Great, thank you. And so once we get beyond that, we're looking at systemic therapies, whether it be SSAs or PRRT or some of the other medical therapies that we briefly touched upon. Just a couple of questions left. Some of them relate to following up. One question for Aaron: how often should I see my surgeon after surgery?
That's a great question. I think often, I typically see patients every 3 to 6 months, depending on their symptoms. If they're doing well, it would be 6 months. But I think it's important to see them, particularly if you're seeing a surgeon in one institution and an oncologist elsewhere. But if you're part of a team, I think as long as the team is keeping an eye on you, it's worthwhile. But patients do have issues come up. Their gallbladder comes up. Their primary tumor, which may not have been completely controlled previously, comes up. So their liver lesions. So it would not be uncommon for patients to be constantly being represented at our tumor board, the same patient every 3 to 6 months as new imaging shows up, because we're planning something else. So even for the patient who has multiple spots in the liver that's been controlled for years, and there's one lesion that's getting larger, well, we may want to remove that one with surgery, or ablate that one with surgery, or embolize that one. So all these things have to be decided upon with the surgeon, or hopefully, if you're at a place at a center, with the team. And so I think that's the value of going to a place that has the expertise in a team approach. But I do think that seeing the surgeon is important because issues will arise that will need to be dealt with, and having that a constant follow-up with the surgeon is valuable.
Totally agree. This should be a team approach. Even my general medical oncology patients, my patients with breast cancer or colon cancer, I have them see the breast surgeon, I have them see the colorectal surgeon on a routine basis as well as seeing me. So it should always be a team approach. And unless you have an aversion to seeing your doctors, you should follow up with all of them. Someone asked about stable disease, liver metastases, stable disease for over 8 years, only on an SSA and getting scans every 6 months. Is it an option to stop therapy and just do observation? I'm going to give that to Diane.
It's a beautiful
tough
question.
question.
It
Yeah.
is a tough question because one of the biggest challenges of our disease is that we just don't have great data to guide or help answer those questions. So in the prostate world, they do this all the time. They stop their hormone therapy, and not only does it not hurt, it actually helps. It actually was found that you could hold hormone therapy called Lupron, and then their PSA goes down when you stop it, which would be a beautiful thing for us, right? We just don't have data. So I can tell you anecdotally, there are definitely patients that had, most times we say that somatostatin analogs, I call them my first string players because they're so well tolerated. So they're a good friend to have for most patients, but not all. Some of our patients do get side effects from these therapies. So we have certainly stopped it in patients that wanted to have a break. And I don't believe that we have any data to suggest if you stopped it for a little while and then if it grew, put it back on, and that they would develop resistance like you would with an antibiotic. But it's just hard to know because it's sort of like if it's not broken, do we need to fix it? So, I think it really depends on that patient, how well they're doing on the octreotide. Have they developed, for example, fatty liver, which is sometimes something that we have to be careful of because we want to do, hopefully, if God forbid it grows, liver-directed therapies in the future, and a fatty liver may potentially hurt that. So I think there's a lot of variables that go into answering that, but I will say that I have in my clinical practice held patients that had been doing well for a long time, and they've actually done quite well.
Don't forget, if you're on a sandostatin or a lanreotide for long periods of time, your doctor should be checking your thyroid function. You should be checking your B12 levels and receiving B12 injections. There's malabsorption of B12 associated with that. So there are other factors involved as well.
And your pancreas too. It also affect your pancreas long term too.
One quick question from me is, why doesn't immunotherapy come into play yet? The shorter answer is we don't have any studies yet that shows it's effective. Immuno-oncology is a relatively young field. It involves the PD-L1 and CTCL4 pathways that recruit and activate T cells, simplistically into killer T cells that will seek out and destroy cancer cells. Immuno-oncology therapeutics doesn't work directly on the cancer cells. It works on your T cells to recruit your immune system to fight the cancer. It was first used in melanoma. The famous one was Jimmy Carter, who was probably the first well-known patient to be treated with Opdivo, and it's now shown to be effective in a wide variety of cancers. And you would think that it would be because, again, it's not tumor specific. So hopefully it will be shown to become useful in more and more tumor types, as it has been. It's gone from melanoma to stomach cancers to lung cancers to breast cancers. So its use is becoming more varied and more widely used, but not yet in neuroendocrine cancers. Diane?
Yeah, I actually have a slide on this for the clinical trials. There was one study that just came out by Dr. Halperin this year from MD Anderson with immunotherapy plus bevacizumab, which is a VEGF inhibitor. So as many of you know, our tumors, as you heard, are very rich with blood vessels. So that combination in a very small study of 40 patients was positive. The problem is we don't know, was it the bevacizumab, was it the immunotherapy, or was it both? Because they didn't have what we call randomized. So I totally agree that the jury, unfortunately, is not out yet with immunotherapy or unfortunately, most of the studies, and there have been many, haven't been helpful in our disease. But I'll talk about that a little bit in my talk.
So I have a question for Eric. Do you know if there's been any progress by Dr. Oberg's group with the use of viruses to kill neuroendocrine tumor cells?
No.
Okay, I have another yes or no question for Eric.
I'll answer that question.
He's very good at the yes or no questions.
Yeah. There was a very famous professor in Sweden named Dr. Kjell Oberg, who was a huge expert in neuroendocrine. And about maybe a decade ago or something like that, they were working on what they called an oncolytic virus, which was a specially engineered virus that was able to bind to somatostatin receptor, and it was like an adenovirus, like a cold virus-based thing. And it was quite clever and brilliant. I mean, if you think about it from a scientific perspective, but they had a whole bunch of problems getting it through a clinical trial. So unfortunately, it's just kind of stuck. But oncolytic viruses are a huge, massive topic in general oncology. So I hope someday someone develops a magical oncolytic virus for us. That'd be fantastic.
Okay. Eric, is the NIH the only place that has the F-DOPA scan?
Yes.
That was a yes or no question. And have they found, this is for the panel, have they found a genetic connection or blood test to show gene markers? Now, I know the NIH did have a registry for family history, but I don't know if there's been any shown to be a genetic connection or blood test. Does anybody have any information on that? Diane?
I don't know if I completely understand the question. I will say that there are blood tests where you can get cell-free DNA in the blood. We actually did a study that we're hopefully presenting at GI ASCO that in certain types of neuroendocrine cancers, pancreatic neuroendocrine in particular, you can just do a blood test and identify the mutations from the gene. So the cells are shed enough that in the blood, it's actually a high rate of being able to detect that DNA. But that is the gene damage or mutations from the pancreas itself. We also, most next generation sequencing platforms do have the ability to test your own genes passed down from mom and dad to see if you have a genetic mutation that was passed down. As we know in our disease, that's very, very unlikely, thankfully. So you can do that by way of a blood test as well. So it's probably less than 5% of our patients that have that. But yeah, any family history suggestive neuroendocrine, that absolutely should be something that people get tested for.
Two more questions, Bob. Okay. The next two questions are, is there research still being done for sandostatin in pill form? The answer is yes. And to go along with that is, what hospital in New York are doing studies for neuroendocrine tumors? Diane.
Yeah, well, there are many. And I'm in my talk, stay tuned, we'll talk about some clinical trials that are coming up.
Great. And any studies going on in your center, Aaron?
Yeah, sure. We'll have Dr. Gilmore present some things that we're doing for neuroendocrine tumors as well.